Okay, let's do this. First webinar ever. Welcome, everyone. My name is Dominique, and I'm a health coach. I own my own business, DG Health Consulting, as well as I have a podcast. You can find me on YouTube searching Dominique Podcast, all one word, and my website is dgconsultandcoach.com. But don't worry, I will have all the links in the description wherever you're watching this. So I know firsthand what it feels like to be in menopause, to be exhausted, moody, achy. That's why I've taken my 30 plus years in the health and wellness industry, my experience as a gym owner and trainer, my last role as a representative for a compounding pharmacy, where I educated doctors and nurse practitioners on all things bioidentical hormones, peptides, IV solutions, as well as combining all of that with my own struggles with autoimmune disease. I turned it all into a way to help both men and women get through midlife with more strength and support so you can thrive instead of just survive this stage of your life. Today's webinar is all about menopause, though. I'll answer some of the most common questions that I get very often, like what is menopause even? Sometimes we don't even understand what's going on or why. But more importantly, what are bioidentical hormones and peptides, and how can they help me through this journey in this transition? And at the end of this free webinar, you'll also receive a discount code for a personal consultation with yours truly, if you'd like one, and then possible ongoing guidance from my nurse practitioner that I have on staff, Susan Tramazzo, which she is amazing. You're going to meet her tonight. She's going to come in on the end of this webinar so we can geek out and get all sciencey. Anyway, I'm excited to share, educate, and support you in this journey. So let's dive in. I'm going to share my screen. Okay. Understanding menopause. Learning how bioidentical hormones and peptides can help. All right. Like I said, we'll meet Susan later. She was in the corner there. So menopause doesn't have to be awful. So much has changed since our moms had to endure it. And I do feel bad. They really did have to endure a lot. Let's talk about how to thrive now instead of just surviving menopause. Menopause is definitely just the natural end of the menstruation in a woman's life. We all know that. It's like God saying, "Okay, I don't need you to make babies anymore," which is sad because I miss my babies. But it's typically occurs between ages 45 and 55, but it varies for each woman. Defined as 12 consecutive months without a menstrual period, marking the reproductive transition. So I know for me, I'm 51, and I know for me, when I was in transition from perimenopause to menopause, that period would be very sporadic, right? And very heavy and very painful. So you might go 3 months and think, okay, this is it, I'm done. Only to find out, surprise, you got your period. But menopause typically is not defined as you're not completely in menopause till you're 12 months without a period. So as we all, I'm sure, know, common symptoms of menopause are hot flashes or the night sweats. I'm hot, I'm cold, I'm hot, I'm cold. We all drive our husbands crazy, I'm sure. Sleep disturbances, and it's a little taboo, but we do have to talk about painful sex because there is vaginal dryness that is a part of menopause. And then the mood changes. I mean, I don't want to swear on this, but I'm sure you've heard the saying, like, my giving a blank meter is no longer in service. You just don't give a crap about anything anymore. So we don't want that, though. We want to still love everybody in our life. The stages of menopause, as we just spoke about, the transition is perimenopause. And I think there's some confusion on this, where perimenopause can last for years and years. You can be on this roller coaster for years. During perimenopause, your estrogen levels are gradually declining, leading to various symptoms such as the irregular periods and hot flashes and mood changes that we just spoke about. This transition can be, I think, I'm not going to put an exact number on it, but it can last up to 10 years for some women. It's crazy. Crazy, crazy, crazy. Basically the timeline of menopause, in your 40s, you will experience probably the perimenopause. And then around age 51, which is what I am, yay. This is the average women actually hit menopause. So I guess I'm right on time. Yay. And in their 60s, women experience postmenopause, where symptoms typically stabilize. But let me say, those symptoms stabilizing are not normal. We've been told, especially our poor mothers were told, it's just a part of life. You're just getting older. This is normal. It's really not part of aging. We shouldn't have to suffer from age 51 until the day we die. It's just, that's not fair. And you don't have to do it anymore. Ongoing management and care strategies become essential for thriving and not just surviving. Okay, common myths about menopause. Myth number 1, menopause means the end of your sex life. No, it does not. Many women remain active and satisfied with bioidentical hormone replacement, I might add. And there is estrogen vaginal cream that's pretty well accepted by OBGYNs, and we'll talk about that. Myth 2, menopause only affects older women. No, I mean, I've had some friends that have hit it very early on, early 40s. Myth 3, hormone therapy is the only solution. Not necessarily. We like to build a nice foundation of lifestyle changes. So I think this is the appropriate place to say to everyone, I cannot give you a consultation and have you see my nurse practitioner and we get you on all these great bioidentical hormones and maybe some peptides if your foundation has not been laid. And by foundation, I mean, are you eating healthy? Are you moving? Are you doing a little bit of weight bearing exercises? Nothing crazy, but are we taking care of ourselves foundationally, emotionally? Do we have a prayer life? Do we have faith? Are we meditating? How are we regulating that nervous system? That all plays into the foundation of a house, so to speak, until you can build the walls and put the roof on. And I always say the walls are your hormones, and then the roof is peptides or icing on the cake. So management strategies, key approaches to alleviate menopause symptoms effectively. The lifestyle adjustments I just spoke about. Bioidentical hormone therapy. You'll hear me call it BHRT. That's interchangeable. May be a viable option for some women. Again, you should be evaluated by an integrative practitioner. And we'll get into how traditional Western trained doctors and nurse practitioners, unfortunately, are not trained to help you through menopause. They're just not. They have a basic understanding of the body, which is great. It's a great foundation, but they too need to build their walls and their roof, just like we do. And that's only done if they seek it out themselves, additional credits and education. And last, non-hormonal treatments like peptides. And we will talk a little bit about that as well. So bioidentical hormone therapy. Understanding the benefits of bioidentical hormone therapy versus traditional treatment. So BHRT can effectively relieve hot flashes and other menopausal symptoms. It is the use of hormones that are chemically identical to the ones in the human body already. It's chemically identical. Yes, they are compounded in a compounding pharmacy, but it's chemically identical to what we had in our bodies. And to help restore balance during hormone decline. They come in the forms of oral, pellet, and transdermal cream. I favor transdermal cream, which we will get into as to why. And I'm going to pause here to let Susan in because she just joined us. And let me I'm going to let her know. Give me 1 second and she can just join in my slideshow. Okay, we are back and we are welcoming, as you can see in the little screen below me, Susan Tramazzo. Hi, Susan.
Hello. Hi, Dominique.
Welcome, welcome.
Thank you for having me.
So we're going to introduce Susan and get into some Q&A with her in a little bit and tell you about her background, but I'm just going to keep flowing through the PowerPoint. And then Susan, if you want to interject at all, please do so.
Excellent.
All right. So we're up to studies on hormone replacement therapy. 1990 to 2002, the WHI, which I'm sure a lot of women listening to this has heard of, the Women's Health Initiative, they conducted, and by the way, I'm dumbing this down for time's sake, but they conducted randomized trials linking estrogen plus progestin therapy to increased risk of breast cancer, cardiovascular disease, and stroke in postmenopausal women. Hence, our poor moms went through menopause and suffered. I really do look back at all of the symptoms my mom was having, and I would get so annoyed by her, but now I feel bad for her
Mhm.
that I've gone through it, and knowing that she didn't have the choice of bioidentical hormones. So then come, the mid 2000s and on, and over time, the WHI results were formally debunked through scientific reanalyses. Again, you can look all of this up on Google, PubMed. I just did not want to get into the weeds in this webinar with getting into all of this. So I'm just glazing over it. And then in 2020, the WHI did a 20-year follow-up, and that you can find this in JAMA. In women with prior hysterectomies, estrogen alone was linked to lower breast cancer. So can you imagine how women felt? And I can only imagine how Susan felt being a practitioner in the medical industry, that, this big study comes out and we should counsel the patients that it causes BHRT causes breast cancer. Oh, wait, 20 years later, I'm sorry, my bad. No, it doesn't.
Right. Yep,
Kind of,
and still debunking, the cardiovascular risk as well. We now know that cardiovascular risk increases when we don't replace those hormones, which is the
wow.
opposite of what the original study kind of made everyone fearful about.
Awesome. Thank you so much. That's why you're here. I told everybody we were going to geek out and get sciencey.
Yes, I love it.
So now ongoing, several studies in the New England Journal of Medicine show that estradiol replacement slowed, as Susan just said, atherosclerosis progression and reduced heart attacks, improves bone health, preventing osteoporosis, and lowers the incidence of breast cancer. Now, do you find all of that to be true? Because I always like to back myself up, my research.
Absolutely. The only people who were really very, very cautious in any estrogen replacement is those who are BRCA positive, who have the BRCA gene, because we know that their inherent risk for breast cancer is already much higher. And if there were microscopic breast cancer that was there, estrogen feeds certain types of breast cancers, not even all. But even still, it can be a risk versus benefit discussion for anyone. It doesn't have to be this is completely off the table because you're BRCA positive. It can be a discussion.
Oh, awesome. Thank you. And for those listening that have never heard of that gene, could you just briefly explain what that is?
Absolutely. It is the breast cancer linked gene. So when we discovered, yes, decades ago, we always knew that certain cancers, in particular breast cancer, was genetically linked. And when they mapped the human genome, we were able to find the exact genes. And BRCA, that breast cancer gene, has a couple different types, but we were able to specifically identify who had the highest genetic risk based on their family history.
Wow. And isn't it amazing? I'm not going to go down a rabbit hole, but I just find the whole genetic testing amazing. And it is my dream, and I'm sure I'll see it come true very soon, where medicine becomes so personalized. You enter a physician's office and immediately you just get a genetic test so that they can target what gene mutations you have, what genetic
Exactly.
factors you have, and then they can personalize everything.
Yes.
I'm just curious, how close do you think we are to that?
Well, yeah, it's fascinating. And that is definitely where the wave of the future is in medicine, is genetic testing and really honing in treatment for the individual. In my family practice, I'm already doing that for patients and mental health medications.
Wow.
There actually is a genetic test. It's an oral swab. And it's especially helpful for people if they've tried many different mental health health medicines for depression or anxiety and just haven't felt like it works well for them, where these genetic tests can show, here are the ones that will be the most successful for you. Here are the ones that your body does not kind of genetically mesh with. And that really is the wave of the future in medicine in general. Because we know that we are individual beings and that we all respond differently to different things. Before, that was all just anecdotal. But now we know we have the ability to really hone in on what the individual body will do best with. So I hope we see that, especially in the hormone space. But it's, it's, all research and medicine stuff happens slowly, but I hope in the next decade we really see some big advances in genetic testing and honing that in for the individual treatment.
That would be exciting.
Mm-hmm.
Okay, so getting back to the hormones, it can get very complicated. Again, this is just a nice little quick free, tutorial for people. So the big three of BHRT, estradiol, helps reduce hot flashes and night sweats, protects your bones, supports vaginal and urinary health, and improves mood and skin. Progesterone balances estrogen's effects on the uterus, which I'll ask you about that later. It's important to have those both. Promotes better sleep, reduces anxiety, and may ease hot flashes. Whereas testosterone, and yes, ladies, we do need testosterone. Like Susan already knows how I feel about it. I am like pro testosterone for women. Although many people would tell you I don't need any, that's for sure. But yeah, testosterone supports energy, libido, muscle strength, and may improve mood and cognitive sharpness. And if I may interject here very quickly, when I went through menopause this past year and I called you Susan, I didn't even feel like myself. I was really scared. And not only was my sleep disturbed and I was having the night sweats, which is the estradiol and the progesterone, but what really scared me for the first time in my life was I had no motivation or drive to do anything. I was getting very depressed. And the minute I added just a touch, because women don't need a lot, but just a touch of testosterone, I can't even explain to you, and I only do it like 2 to 3 times a week. I can't explain to you the difference it's made in my mood, my motivation, my gym time, like all of it.
Absolutely. And so many women, that is, even, if you go to a GYN who is supposed to be an expert in menopause and women's hormones, they often don't test the testosterone. And even if they do, they don't look at the individual and their symptoms. There's a range of what's normal. And so if it falls anywhere in normal, many doctors will say, well, you don't need it. But when we look at the symptoms of muscle mass loss, fatigue, decreased libido, depression, that all can be so tied to testosterone. And like you said, just a touch can make a huge difference. So it is definitely a hormone that gets forgotten in menopause and is so important. Not every woman will always need that being supplemented, but every woman needs to have it checked and addressed and discussed if it could be a helpful part of the regimen.
I'm so excited that we're talking about this. Seriously, because so many women their doctors are not educating them.
No.
So this is a perfect segue. I'm so glad I put this particular slide here. Let's talk about normal lab numbers. And if I may, I'm glad you're here during this instead of bringing you in at the end, because I'm an avid researcher and reader, but I pride myself on bringing correct information, and I never want you to feel bad about correcting me if I'm wrong, because I want to get correct information to women.
Right. And it's hard to get correct information because there's so much information out there. And even as medical professionals, sometimes we don't know what to trust because the menopause data in particular is not great. So it's always great for people to ask questions and say, is this a source that is correct? Am I asking the right questions? That's how we all learn.
Good. Okay, so when it comes to lab results in general, this is what I've read, and you correct me if I'm wrong. When you look at normal on lab results, the labs are comparing you to the rest of America.
Mm-hmm.
So they take this data pool and they pit you against everyone else in America. Do I have that correct?
That's correct.
So I'm going to go out on a limb here, and I'm sorry if anybody gets offended, but I don't want to be compared
Yes, to
to the
anybody.
average American anymore, because it's not our fault. The food supply and pesticides and plastics and on and on and on that I could do a whole webinar about.
Mm-hmm.
I'm not blaming anyone at all, but I'm saying we are all walking dumpster fires. We are. Even if you
We
don't look
are.
like it, you are inside. Okay.
Yes.
So I don't want to be compared to that. I mean, I might look like a rock star because the rest of America is just so messed up from everything that they're hitting us with.
Mm-hmm.
So I love about you, Susan, that you keep that in mind, and you look at, as a practitioner, as a responsible nurse practitioner, you will look at the lab results, but you'll also, as an empathetic person, listen to your patient. And if they're telling you, I know my lab result, I know I'm in range, but I really still feel awful, could we try just a little bit? You will address their symptoms as well as their lab results, will you not?
Absolutely. That is, I think, the most important thing in hormone care, and especially in menopause care, because menopause doesn't really play by any rules.
Mm-hmm.
There's a lot of things in medicine that play by some rules. Blood pressure. We can play by some pretty normal rules in blood pressure. Here's the normal numbers. Here's the medicines that work. But menopause doesn't play by those rules. And it really is every woman's own individual journey. And there's ranges of normal for a reason. And someone might feel fine at a lower end of normal in that range, but someone might feel awful in a lower end of normal. Someone might be sort of smack in the middle of the normal range, but they still don't feel good. So numbers matter to an extent to make sure that something isn't so out of whack that we think something else is going on. But the numbers have to be connected to symptoms, hot flashes, mood changes, sleep issues, joint pains. I have a lot of women who I hear they have their joint pains and aches, body aches dismissed as, well, you're getting older, it's maybe a little arthritis. Many of these are linked to hormones. So when we look at the global symptoms and then we look at the numbers, we can tweak it to the individual. These symptoms are every bit as important, if not more in some cases, as the numbers are in menopause.
Awesome. Thank you so much for addressing that. Okay, so having said all that as a preface, let's get into what is normal. Estradiol, or E2, is this accurate? This is what I found in my research. Less than 20, and then you can explain what PG per ml are.
Mm-hmm. Yeah, so basically we're looking at sort of an amount of that hormone in the blood per milliliter of blood. And estradiol and estrogen, we look at in slightly different ways. They all go together. But, when we're looking at menopause, yes, once it's gone under that 20, kind of with how much is in the bloodstream per milliliter of blood that we're looking at, we consider that to be menopause.
Okay, wonderful. And progesterone, 0.2 to 0.8 NGs per mLs. What is that?
And again, it's sort of looking at, an amount of the usable hormone of progesterone in the bloodstream. This is typically the first one we'll really see drop. Some labs will say 0.5 or lower. Again, there's a range, and different labs can be slightly different. But that means that we're really no longer producing progesterone, which is kind of in general thought to be more of a pregnancy hormone, a hormone that we need to get pregnant. And so when we see that fall, we know that that fertility is not there anymore. And we can pretty much say that the ovaries are not producing the hormones that they were producing when we were younger.
Okay. And then testosterone, again, these numbers in my research were all for menopausal women. So, 7 to 40, and then free testosterone is important as well. And I'll let you explain what that is, because I'm real big on that too, because so many times I've had clients that I've sent to you and their testosterone was fine, but the body wasn't converting it. So you could have really nice testosterone, but if your free testosterone's off, it means your body is not converting it, correct?
Absolutely. Yep. And often what I'll see here is, like you said, because women do need some testosterone, that helps with motivation, with energy, libido, muscle mass. And often, yeah, I'll see someone's total testosterone, kind of the total amount per milliliter of blood, probably smack in the middle. But then when we look at the free testosterone, what's sort of bioavailable to the body, what has been converted for us being able to use it and convert to lean muscle and use it for those symptoms that we need it for, free testosterone matters because often that'll be low. And that tells us, it just gives us an added assurance that, yes, a little bit of a supplementation is going to help here, even though your total testosterone might be right in the middle, your body's not utilizing it in a great, efficient way. So it's an important piece to look at.
Awesome. Thank you for addressing that. And I added an honorable mention. So DHEA is a precursor hormone that can gently support energy, libido, mood, and vaginal health. And then pregnenolone is also known as the mother hormone. Interestingly enough, I saw an integrative physician. He was a medical doctor, integrative in Philadelphia years ago when my daughters were little. And I didn't even know what pregnenolone was back then, but apparently I was really low on it. I have a history of hormonal issues with PCOS and everything, but I wanted to mention these because I don't want women to think it's as simple as, estrogen or estradiol, progesterone, and testosterone. It is such a female's hormonal makeup is such a symphony. It's a beautiful symphony of work.
I like that. That's a great way to say it.
Yeah. So, I come across clients during my consultations. I see that they're on DHEA and I question them like, well, why are you on that? They really don't even know. So, not to get in the weeds on this, but do you have anything to say about either one of those? And if you don't, it's fine.
Yeah, the pregnenolone, I don't have as much experience with. That does tend to be a little bit more in the functional medicine space or in the endocrine space where there have been some other hormonal issues that have made it hard for the body to respond to some typical hormone replacement therapy. DHEA can be a great complement to estrogen therapy, though. Like you said, it's kind of a precursor hormone, and it can absolutely just balance things a little bit when, if we have someone on the full hormone replacement therapy, but they're still feeling like something's a little off, it can just support the hormones in almost more of a supplemental type way, the way that we would take a multivitamin. It's not going to fix everything, but it can supplement what we're doing and support the good things we're doing.
Well, that's good to know.
So, yeah. And luckily, and you have to kind of be careful and make sure you get good quality things. But DHEA is available, in many good over-the-counter sources that can be added in just to support, like you said, that symphony and support how they all work together.
Awesome. Okay. Moving on. So, BHRT, there's 3 delivery methods. There's oral. So if any of this is different, please jump in. What I found was estradiol and progesterone can be delivered orally. I mean, I knew that because I've been on them orally. I didn't have good results orally. That's just me. Everybody's totally different. Oral estradiol may increase clot risk more than other delivery routes. Pellet delivery, pellet implants are placed under the skin, usually in your butt, and it can deliver estradiol and testosterone. However, many patients experience a surge of hormone release the first week or 2, and then the hormone levels taper off toward the end of the 3 to 6 month cycle before receiving the next insertion. Again, anecdotally, my friends have been on the pellets. They didn't care for them. Honestly, they thought they were like great at first, but after that initial surge and they start to come down and feel really awful, but their appointment isn't for 2 months. critical thinking skills and just being a logical person, I'm just like, I'd rather control it
Right.
myself. Yeah.
That's kind of how I feel as well. And it's all anecdotal, and I'm not a pellet expert at all. There are lots of hormone clinics out there that really are sort of experts in pellet therapy, and women who do like it. But it's true, there does tend to be that surge, and then feeling a little bit more crummy as those 2 and 3 months progress. And once that pellet is inserted in there, kind of deep in that tissue, it's in there. There's no adjusting. Whereas with orals and creams in particular, we can kind of adjust as we go, and we can tweak those along the way and tweak them based on symptoms, and kind of do that in real time, which I really like.
I do as well. The transdermal delivery, my favorite, comes in the form of patches, creams, or gels. And I use a cream, and it can deliver all of them: estradiol, progesterone, and testosterone, with less impact on the liver, because obviously anything taken orally has to go through the liver. So the liver metabolism is saved there. I understand there's no perfect solution to anything, and I do get the cons to creams, and that is you forget to take it. Even though it's like a click, I notice sometimes if I'm just starting mine or I'm at the end, who knows how much I'm getting, because the click might be a little off. I've always been a person where I'm not super like, I need everything uniform, but there are people
Right.
like that. So you have to keep that in mind, and you have to remember to do it,
Mhm.
whereas the pellets, I get it. Like, you don't have to remember anything. So I think it's important for everyone to know that you have to pick what works best for you. I'm just speaking anecdotally through my clients, myself, my friends. It seems to me that transdermal would be the first favorite, oral second, and pellets last. That's just my experience.
That's how I feel as well. And again, yeah, it's just an individual conversation to say, hey, here's what my life looks like. Here's what I think is going to be easiest for me to start with. And yeah, then you go from there.
Yep. Okay, so I think we just went over this. Basically, I'm being redundant at this point, but why transdermal cream? Why do we like that? More stable hormone levels, lower risk of blood clots and liver strain, easier to adjust the doses, non-invasive and convenient, and compounded by pharmacists at compounding pharmacies, and they dose them specifically as per your practitioner. So I get my lab results done. I talk to Susan. She calls it into the compounding pharmacy, and it's based on my personal needs. It's not, I think I didn't have a great time with the progesterone oral pill because it was just a straight milligram, and the adjustment was very hard. They were like, well, you got 50 or 100. We can't really do
Mhm.
anything in between. But with the cream, there's so much more flexibility. Would you agree?
Absolutely. Yeah. The for both estrogen and progesterone, oral forms, and some people do great with them, but not everybody absorbs all that well through, yeah, the gastric system, especially if there's some things like IBS or things like that. But yeah, the pills with estrogen and progesterone tend to be a little more one size fits all,
Mhm.
kind of like traditional medications, whereas the creams can be really completely customized. And like you said, since the creams are a click, even within that customized dosing of what the actual cream has in it,
Mhm.
in real time, I can say to someone, if they feel like maybe it's a little too much, we'll say, okay, do 1 click of your cream a night instead of 2.
Yes.
Or on the other side, if they feel like I'm not quite seeing the results I want to, we can say, okay, let's go up to 3 clicks of cream,
Mhm.
see how that feels for this week. And so it does just give us much more individualized treatment.
Yes, I love it. I love
Yep.
it. Okay, so when to seek help, understanding what kind of practitioner to seek out and how to be your own healthcare advocate. It is a well documented fact that physicians are not trained, and Susan can correct me if I'm wrong, in how to treat menopause. I'm sure it's glazed over in medical school, but
Mhm.
even especially not using bioidentical hormone replacement therapy, but not even our beloved OBGYNs. And I love my OBGYN. I've been going to him since I've been a young girl. He delivered both my babies, but he's so great because he's so old school. He looked right at me because he knows how I am. And
Yeah.
he's like, listen, I'm not going to lie to you. The best I can do is give you some estrogen vaginal cream. I don't know anything else about what you're talking about.
Yep.
And he's
It's
humble
true.
enough to admit it. And that's why I love him, you know?
Yes.
But it is crucial to seek out a traditionally trained medical doctor or nurse practitioner because we want a Western trained, educated physician or nurse practitioner because we obviously want you to understand how the body works, but we also want you to have sought out that additional education after medical school to make you that integrative practitioner. Now, health coaches like myself with a science background, I went to college for occupational therapy, so I had all the classes like a nurse would take, health and wellness backgrounds, fitness experience, my own journey to my optimal health with my autoimmune issues. We're also a great resource as well, as long as we always have someone like you, Susan, on the team. I'm not here to prescribe anything or tell anybody what to do. I always like to say, and I stole this actually from one of my podcasters that I love, Lisa Turkhurst, but she always says, I'm not going to tell you what to do, but I'm going to give you things to think about.
Mm-hmm.
And that's, I want to really empower women to know that the information is out there. It's not scary. It doesn't have to be confusing anymore. And if you get a health coach that can look at your whole supplement regimen like I do, and at least coach you on basic lifestyle issues like diet and exercise and supplement regimen, as well as I'm studying to get my life coaching certification. So I'm addressing all of the mental, emotional, spiritual, nervous system kind of issues as well, because that's a big part of it. But once we lay that foundation and we pour that cement when we're building our house, the walls are the hormones and the peptides are the roof. So
Mm-hmm.
I always tell women, let's look at everything first in a consultation with me before I send you to Susan, because you might not even be to the point where you need bioidentical hormones. We have to clean up your lifestyle first.
Mm-hmm.
Then if you're still not feeling better, we're going to look at your your hormones rather, see if you need bioidenticals. And I like to include in that thyroid
Mm-hmm.
and looking for some autoimmune issues, because that all plays a factor. And then peptides. I refuse to suggest any peptides to any of my clients until they do all of that first, because I cannot throw a peptide on top of a dumpster fire.
Right.
It's not gonna do
It
anything.
won't do it. Right.
Yeah.
Yep.
So what would you like to say with that whole thing?
Yeah, it's true. You get that foundation, and it's important just to find someone who you think, is listening to you. I think that's the first thing, and where you feel like you can ask questions, because a lot of women feel like they'll ask about hormone therapy and they'll kind of get a very just sort of black and white answer. And they don't feel like there's enough room for gray, for supplementation, for peptides, for asking questions. And like you said, in Western medicine, we are not necessarily trained in a lot of this. And sadly, the good research that we have now on bioidenticals is newer. So, we're probably just now seeing a generation of med students who are maybe just now hearing some more up-to-date research on hormones. So yeah, you really want someone who has taken the time to do some extra study, diving deep into older information as well as the new good information, so that that can all be married together. And but it's just important to have someone who you can have a conversation with about all the aspects of it.
I'm glad you brought up conversation, because there's a lot of telemed places now, and I'm sure a lot of them are great. However, just me personally as a health coach, I always want to send my clients, if they want to become a patient, I always want to send them to someone personal like you, that's going to either do a video chat with them or a phone call, and they get to talk to a real life human. A lot of the I caution everybody listening, because a lot of the telemed places now are simply sending you a form, and you fill out this form, and then they send it to some doctor, which I don't know, are they really? I hope they are.
I know.
And then It's kind of scary. And then the doctor prescribes something for you. Okay, but what if you have questions? What if you don't agree with it? What do they know your background or your history? Or maybe there's something that wasn't on the form that I don't know. The whole thing just is so I know I'm old school, but the whole thing just seems like I don't know. I don't trust
I
it.
agree. I think because there's a lot of buzz these days about bioidentical hormones and peptides and wellness and menopause, which is good. It's good that there's more buzz about those
Mhm.
things.
Yeah.
But I think because of that, people have also taken the opportunity to sort of get a quick business thing going where, yeah, you'll be connected to an actual provider, or there's an actual provider sort of behind the scenes to prescribe. But in many cases, I've heard with some of the online places, the main interaction with the patient ends up being sort of a sales representative,
Yeah.
where, the sales representative will do the intake and talk about, what's available to them, which is good.
Mhm.
But it ends up being more about sort of a sale of product sometimes. And then there is not always the opportunity to ask questions of the actual provider. When questions are asked, sometimes you're just getting more sales information about, well, you should try this or that. But you really want your main conversations to always be with your provider so that you can go through the specifics of what's going on with you and your health, not necessarily about what other product should I try.
Yeah, I'm glad you addressed that. Thank you so
Yep.
much. So here's just some, I've helped. Okay, so we're gonna go over your background right now. So, I already told everybody I've been 30 plus. I started around age 20, so I've been 30 plus years. Can you just share with everybody a little bit about yourself and your background?
Yeah. So I'm a family nurse practitioner. I started my career in 2001 as an RN. I was studied nursing undergraduate, was an RN for 7 years, then went back to get my master's and my more medical training to become a family nurse practitioner. And I've now been a family NP for almost 16 years. I've practiced in a variety of settings, infectious disease, full family practice. I've worked in corporate medicine, and now I'm in private medicine, which I love because it gives me the opportunity to really be very personalized in how I give care. But I have also, as I've done my own private practice now for the last couple of years, done more of my own research on the newer information that we have on bioidenticals and really delving into how I can help both men and women in the hormonal space and connect that to our general primary care, all the things that go along with that, right? Making sure thyroid is okay and heart function is good, and looking at weight, and looking at blood work, looking at mental health. So so my training is fully as sort of a general practitioner in family primary care with that extra knowledge in hormones because it's a definite passion of mine.
Awesome. Thank you so much. Yeah, I'm glad you mentioned men because there's a lot of, probably only women listening to this, and they all have men in their life, and we care about them and we want them to be healthy as well. And I will do a whole separate podcast about this, but as you know, we are bombarded with so much plastic and
Yes.
pesticides, but mainly plastics, that I am shocked. When I started this business, I was shocked when I never asked them because it's none of my business, but they always say, would you mind if I share with you? And I say, sure. And even my younger guys in their 20s, their testosterone, oh my gosh, it's like 200, 300.
Yes, I'm seeing, in the 25 plus years that I've been, in the medical world, it's definitely been a change where we're seeing younger men with lower testosterone, where we know in girls that we see hormonal changes and starting periods younger in girls. So really across the board, and it's often stuff we just can't quite control, but we are seeing impacts to our hormones in our bodies. And so it's important for men and women to understand where their hormones are and to listen to their bodies.
I'd actually like to bring you back on, and I'm going to create another slide deck just for guys. Would you be willing to do that?
Absolutely. I love, being able to talk to men about, their health, their cardiovascular risks. If their testosterone is low, we jokingly will call it like menopause,
Yeah.
but, it can even affect, younger guys. And sometimes men might feel some mood changes or changes in libido or energy, but might not always, kind of connect the dots or bring it up to someone. And it's important, for all of us, like I said, to kind of listen to ourselves and know that something isn't quite right.
Yeah, and I will do a totally separate one on just peptides, but just to quickly, because I did promise everybody to touch upon that. Yes, there are peptides for libido. There are peptides for menopause. There are peptides for joint aches and body pains. BPC 157 is great for your joint aches. There's human growth hormones, secretagogues. You have tesamorelin, sermorelin, ipamorelin. Women do great on ipamorelin in menopause. But I really, it makes me sad to see a woman go straight to ipamorelin when she didn't even look at her hormones.
Yep. The foundation, like you said, if you're looking at a house, the foundation has to be built first. We get all of that foundational stuff kind of corrected and in check and in balance. And then we can add some cherries on top that can really help with some of the other things. But the foundation has to be set first.
Absolutely. Absolutely. So, to wrap this up, we've talked a lot about how to stop surviving and just thrive during menopause. And I'm going to put the links in whatever platform people watch this on to my website. They can use this. It's Menopause 20 code to get a discount, $20 off of a consultation with me. And the way it works is they'll have a consultation with me. I'll kind of be like that front person for you and decide if they should even go see you or not. And if so, we have memberships on my website. There's one just for me. There's one that they get you and I both. And it's great having a membership. It's super inexpensive because they get full access to you during business hours to keep adjusting and to keep improving if things come up, which is wonderful. I'm super excited to have paired with you. As you know, I'm your biggest fan.
Well, thank you. I am such a fan of you too. It's been such a great, just partnership in helping people obtain wellness, kind of in all the things that word means.
Yes, absolutely. All right, Susan, thank you so much. I'm going to let you go and I'm going to wrap this up for everybody.
Thank you.
You have a lovely evening.
You too.
Okay. All right. So hopefully you enjoyed that. As you can see here, I did put the Menopause 20. You're going to get $20 off your consultation. It's usually $89. So you'll get $20 off. You just go to my website, click on schedule consultation, and it will take you immediately to a checkout page. Put in your credit card, and then a calendar will pop up and you schedule with me. It's that easy. You can reach me at dgconsultandcoach@gmail.com if you have any issues with that as well. And I have thoroughly enjoyed this tonight. I have so much more to my story to share with you, but I just wanted to give you pretty much just a general overview of what menopause is and what you can do about it and how you can feel better. And I 100% am telling you the truth when I say I felt like a completely different person about a year ago. And I was in perimenopause up till then. I knew it was coming. I knew it was coming. And I was so scared. I'm like, no. But finally, when my menstrual cycle stopped and it hit me, I was a different person in all ways. Mood, libido, motivation. And I do my estrogen or estradiol and progesterone cream at night. And then I do my testosterone in the morning. I do my estrogen, progesterone every night, my testosterone only 2 to 3 times a week. And I like to separate them because testosterone tends to give you a little energy. So I don't like them in the same tube as my estrogen and progesterone. That's just me. And we only deal with compounding pharmacies. So again, changed my life. And then I add the peptides on top of it. I will follow up with some podcasts and webinars about peptides and bioregulators and what they are and how they can help you as well through menopause, but they definitely are the icing on the cake. So reach out to me, please. And I hope you enjoyed this free webinar. And hopefully I will be talking to you soon. Okay, thanks.